putting more into the concept of harm reduction, trying to keep people alive. We'll be having an announcement in this month of, you know, September is Recovery Month nationally, and we will be making some announcements probably around the middle of the month about some new initiatives that we have to, in every way possible, keep people alive and have so that they have the hope of recovery. In the housekeeping, all I have to announce is that there'll be no, there are no financial or other conflicts of interest for our faculty this morning. Those of you needing CMEs or CEUs will complete your evaluation form and receive your certificates once your evaluation forms are completed. For the question and answer period, because there are hundreds of people on the call, we're going to ask that you can't unmute yourself in this format in any case. So we're going to ask that you go to the question and answer box at the bottom of your screen, which is right next to the chat box, and put in your question. I will then moderate those for the last few minutes of the seminar, but we anticipate that we'd never get through all of them. And so we're going to answer your questions in writing, put those on the seminar website, which is accessible from several different vantage points, including the AdCare website. And we will answer all your questions just as soon as we can. I think my last announcement is that because this is an educational program, it's important to recognize that some of the positions and advanced by the faculty in any of the 10 programs are not necessarily to be taken as a position of Governor Mills and the administration. This is about education. We are very open to every idea imaginable as to how we work on these problems, but we're not committed to necessarily every idea that's advanced in the 10 seminar series. I think you can all understand that. So without further ado, I'm going to introduce Dr. Thakarar, then I'll introduce Jamie, and then Jamie's going to go first and give us some highlights of the current status of our syringe programs, and then Dr. Thakarar will share some slides, and we'll be all done by 12:30. So Kinna is an osteopathic physician with a master's of public health. She's an assistant professor of medicine at Maine Medical Center, Tufts University School of Medicine. She's an infectious disease physician with a special interest in addiction. And she received her BA in health and from the University of Pennsylvania, her osteopathic doctoral degree from the Philadelphia College of Osteopathic Medicine, an MPH from the Bloomberg School of Public Health at Johns Hopkins. She did a fellowship in infectious disease at Boston Medical Center and her residency at Cambridge Health Alliance. She is triple boarded in internal medicine, infectious disease, and addiction medicine. She's affiliated as well as an investigator with the Maine Medical Center for Health Outcomes Research and Evaluation, where her research currently focuses on the intersection between substance use disorders and infectious disease. If I go on, she's going to be even more embarrassed than she already is. Jamie also has a master's of public health. She's the associate director of disease prevention at the Maine Center for Disease Control and Prevention. She assumed that position January 1st, but had been in previous positions at the Maine CDC for about 13 years. She got her BS degree from the University of Maine and her master's in public health from the University of New England. So I think that's all my preliminary matters. I am going to mention just 3 upcoming events in case I forget at the end. We have posted the information on the Maine Harm Reduction Conference, Friday, October 30th. That's a virtual event, always a valuable event. Zoe and her team do a terrific job of that. We also, on September 30th, the Maine CDC has its Maternal, Child Health, and Substance Exposed Infant Virtual Conference. That's an annual conference. This year's theme is Continuing the Journey to Healthier Families. That's also a virtual event. And then on October 2nd will be our second seminar series, and the topic will be reducing stigma and efforts in the state to do that, stigma around substance use disorders. So Jamie, the floor is yours, and thank you for being with us this morning.
Thank you, Gordon. I really appreciate the opportunity to be here with everyone today. And thank you to everyone who is here joining us virtually. This is becoming more comfortable, I guess, as the days go on. It just seems odd to be looking at myself, Dr. Thakarar and Gordon, and not being able to see all of you out there. So thank you for joining us today. I'd like to begin my talk today really by thanking Gordon and Governor Mills' office for their support of syringe service programs, which will be the focus of my brief chat with you today. They, through their hard work and advocacy, syringe service programs have really been able to expand in the state of Maine. They ensured that we had $1 million in funding, which has really changed the landscape of syringe service programs. So previous to that, we did have an allotment of state general fund of about $75,000 that went to syringe service programs. But really the work that was being done was a testament to the dedication of the staff and boards at the syringe service programs that were in existence, really fundraising, looking for foundation funds, scraping together resources however they could. And now with this influx of funding, we've really been able to grow programming to a new level, which has been really exciting to see. Despite the pandemic, we've been able to continue to expand. We have wonderful people out in the communities that are looking for new locations, new areas of need to make sure that these critical services can get where they need to be. Also, thanks to Governor Mills and Gordon's efforts, I'm sure, there was an executive order that was issued during the pandemic that allowed our existing exchanges the ability to adapt to continue to meet the needs of folks. We're in a very strange time, a necessary but strange time, and so we have great staff that are working at these exchanges that have done a really wonderful job of adapting. So I could go on and on with my gratitude to Governor Mills' administration and Gordon, but I do want to talk a little bit more about the syringe service programs themselves and the work that they're doing and how harm reduction is really a key tenet of the work that's happening. So Maine currently, I'm excited to say, we have 11 active syringe service programs in 8 counties, and we have several more programs that are working to open hopefully by the end of this calendar year. It's a really great thing to be able to say that. I started my career in public health working at a community-based organization many years ago at one of the first syringe service programs in the state of Maine. And so I feel very fortunate that I was able to see firsthand how working at the staff at the syringe service programs really can develop critical relationships with the folks that are using those services. We're able to really become a trusted resource, an ally for them to make sure that those folks get access to information that they might not otherwise have access to, as well as services that they really might not be aware of, either how to access or where to access friendly services, those types of things. And so, I just can't say enough about the importance of developing relationships with these folks that are accessing the services, because oftentimes they feel marginalized. They have distrust of anyone in an authoritative or professional role. And so one of the great things about having these syringe service programs is that the staff are able to develop relationships and build trust and then make key referrals for folks. And so one of the things that we're able to measure and track with our work with the syringe service programs are the referrals to these key service points. And those can be anything from HIV and hepatitis screening, hepatitis vaccination, naloxone, which is also a very key new service that's been added under the Mills administration. But the syringe service programs also can provide referrals to mental health and substance use services. And so, especially in this time of COVID, where we're seeing, as Gordon stated, more and more deaths, I really can't emphasize enough how important that connection that can lead to referrals to these services is. It's just really, really critical. And it's great when you see those referrals result in a life-changing event for someone in a positive way. So syringe service programs, one of the things I also want to highlight is that we've really shifted away from the term needle exchange. And now we're talking about them as syringe service programs, because they do provide so much more than simply exchanging needles from used needles to new needles. And these referrals and access to information really are critical. And so you're going to see the shift from the acronym NEP and the term needle exchange program to SSP, or syringe service programs. And so syringe service programs really operate under a harm reduction model. We understand that not everyone is ready to make that change to abstinence or quitting, or to get to that endpoint. And so the goal of these programs is to really meet people where they're at, give them information, and be there for them so that when they're ready to make a change, whether, like I said, whether it's getting screened for an infectious bloodborne pathogen, or accessing mental health, primary care, getting health insurance, any of the number of services that these programs provide, those staff are there and they're ready to connect folks. And so, you know, it's important for folks to understand that. You know, I think a lot of folks that are on this presentation have been versed in the stages of change. And so really making sure that we're there when someone gets to that action step, being there from pre-contemplation all the way to action, and helping follow through and support folks and make sure that they get what they need. So one of the things I'm going to do after I get done talking, because I'm not great at multitasking with technology, is I am going to put a link in the chat box to our website that includes a list of current certified syringe service programs. We update this regularly as new programs are certified. And I'm noticing that my 10 minutes are up, so I want to wrap up by again thanking you all for being here today, thanking the administration and Gordon for their support, and I'm looking forward to hear Dr. Thakarar's presentation. Thank you all so much.
Great. Thank you, Jamie. I'm going to try to share my screen here. And while I do, I just apologize in advance. I'm at the hospital and got a little message saying my internet connection is unstable. So if I freeze momentarily, I promise I will be back. So I think as you heard, my name's Kinna Thakarar. I'm one of the infectious disease and addiction medicine docs at Maine Med. And again, I just wanted to thank Gordon and the governor's office for giving me the opportunity to share some of the research we've been doing. And I'm so excited to be here with Jamie to talk about harm reduction. So the title of my talk is Injections and Infections, Understanding Harm Reduction in Our States. And as you heard, I have no financial conflicts of interest, although here are the funders for our studies. And here's a brief outline of the talk. I'll be reviewing the epidemiology of injection drug use associated infections, also doing a very brief harm reduction overview. This could be, a 60-minute talk in itself, but I just wanted to review some principles. And then I'll spend most of the time talking about the Rural Heart Study, which is the study we just wrapped up in Maine, and our ongoing COVID-19 study, and hopefully leaving some time for discussion. So in terms of injection drug use associated infections, really nationally, we're seeing rises in hospitalizations related to pretty serious bacterial infections from injection drug use. This is a study that was published a few years ago, looking at the number of hospitalizations of these infections, endocarditis, which is a very serious heart infection, osteomyelitis, septic arthritis, epidural abscesses. And the authors compared the number of hospitalizations in 2002 to 2012. And simply just looking at the numbers, you can see that the number of these infections have increased significantly over time. And this study was actually published by Dr. Nenninger, who's a preventive medicine fellow at Maine. And our team looked at opioid-associated infective endocarditis using a national data set. And if you look at the graph on the right, the urban areas are in gray and rural areas are in the black boxes. And we looked at opioid-associated infective endocarditis from 2003 to 2016. And as you can see in rural areas, the rates of endocarditis increased from 0.28 per 100,000 to 3.86 per 100,000. And, really, I think this speaks to not only the need for treatment for substance use disorder, but also harm reduction services as well in both urban and rural areas. And, why should we care about all of these infections? Well, one, people are suffering, people are dying from these infections. And also, I think something that people may not realize is these infections are really costly as well to our health system. And this was a study done by a recent graduate from Maine Med looking at infective endocarditis costs in people who inject drugs. There were 42 patients, if you look at the second column, and the median hospital charge was around $150,000 per hospital admission. And for 42 patients, that cost Medicaid around $5 million per year. So again, and if you put that in context or compare that to running a syringe service program, which is, a lot cheaper in comparison, I would say.
Kinna, I want to interrupt just a second to say some of the panelists can't see the slides. Others can see them just fine. So I don't know that there's a good solution to that, but I do want to ensure all the participants that if you can't see the slides, that there's a full recording taking place. And so you will have access to the slides, after the program. So Lorena at AdCare may be able to help us with that. But again, because some of you can see them and some can't, I'm not sure what we can do about that. But you will have access to them, I promise you that.
Yes.
Go ahead.
Slides and links, thank you. And I'm sorry about that.
There's also a printable version attached to the Zoom link email as well.
Yes, feel free to follow along. Thank you. And in terms of how we're doing in Maine, in terms of infections related to injection drug use, so we know that the rates of acute hepatitis C are increasing in Maine. These data looking from 2013 to 2018 show that there was a 314% increase in acute hepatitis C in Maine, at which point we had the 9th highest rate of acute hep C. And again, a majority of these cases were attributable to injection drug use. And same for acute hep B. These data are from 2015 to 2018, again, from the CDC, and there was a 457% increase in acute hepatitis B. And again, Maine had the 9th highest rate. And this is concerning, especially because we have a vaccine for hep B as well. So next, I wanted to briefly talk about harm reduction. Again, this could be like an hour-long talk in itself. So I left a link here to a book chapter, actually, we just published this month on harm reduction if anyone is interested in learning more. So this is just going to be a very brief overview. But as you heard from Jamie, I think, harm reduction is really philosophy and approach, a range of services and policies to really lessen the adverse consequences of drug use and to protect public health. And harm reduction, as she said, really acknowledges that many people are not able or willing to abstain from drug use, and that abstinence shouldn't be a precondition for help. And yes, part of harm reduction is needle exchanges, or SSPs as we're saying now, but it's also about, distributing naloxone, peer supports, community mobilization, being low barrier and allowing people to drop in for services, supervised injection facilities, which I'll talk about in a little bit, and also policy reform. So it really, harm reduction encompasses all of these things. And again, as Jamie mentioned, syringe service programs, or SSPs, they do more than just exchange needles. So there's a lot of great research out there showing that they effectively counsel clients about safe injection techniques. The photos here are some of the equipment that's provided by syringe service programs. There's a lot more equipment than this, but I couldn't fit it all on the slide. They also reduce the transmissions of infections like HIV and hepatitis. So I'll talk a little bit about that at the next slide. They also deliver overdose prevention, education, administer vaccines to clients like Hep A and Hep B, as I just mentioned. And as Jamie mentioned, also they facilitate referrals to treatment if and when people are ready for it. And in terms of the data behind reducing infections and SSPs, there's some really fantastic data out there. This study was just published last year using data from my home city, Philadelphia. looking at the number of HIV cases averted after SSPs were legalized there in the 1990s. And the orange line indicates actual new infections, and then the blue line indicates what was forecasted to be new infections had they not implemented the SSP. And so the researchers showed through modeling that they had averted almost 11,000 HIV cases over 10 years. And that's significant, one, from a public health standpoint, but also, you know, treating HIV is expensive. It's a lifelong disease. People get complications. And so there's some really great data to show that SSPs really do reduce infections. And in terms of SSPs, there are some regulatory barriers, which really vary by state. Before COVID, Maine has had what's called a 1-for-1 needle exchange, meaning it's sort of like it sounds really. You bring in one used needle, you get a clean needle in exchange, and that's actually been lifted in the setting of COVID, which I think is great. And also, drug paraphernalia laws really vary state by state. In Maine, for example, if someone possesses more than 11 needles, they could be punished for that. And that can be really difficult for people who are traveling long distances to SSPs or have difficulty accessing clean equipment. So as I mentioned, harm reduction really encompasses a lot of things, and one piece of that puzzle is something called supervised injection facilities. I imagine most of you are familiar with these, but for those that are not, a supervised injection facility is a medically, legally sanctioned facility where people can go to inject pre-owned drugs under medical supervision. And actually the pictures here, the one on the left is a picture from the supervised injection facility in Toronto that I visited a few years ago. As you can see, it's clean, it's pretty well organized, and the picture on the right is the equipment that they use there. And why should we be considering supervised injection facilities in Maine or in the United States for that matter? I don't have time in this whole talk to go through everything. I did leave a bunch of references on the slide here. But in short, we know that the research is showing that supervised injection facilities can reduce overdose deaths. And there's some great data coming out of Vancouver, Canada, which show that actually there was a 35% decrease in overdose mortality in the neighborhoods just surrounding the supervised injection facility compared to other rates through the neighborhoods. We also know that supervised injection facilities have the potential to reduce infections, particularly reducing prolonged hospitalizations for infections like I talked about for endocarditis and all of these things. Also, the studies have shown that supervised injection facilities can reduce costs. Certainly there are operational costs to start an SSP, but because of the infections averted, like HIV and hepatitis, there's actually cost savings to these facilities, researchers have found. And also research has also showed that there's a reduction in drug use, less needle sharing, and also less disposal of needles in public places. And also these facilities do help to refer patients to treatment. In one study, about 57% of participants had an intake for medication treatment. And so, supervised injection facilities are not, they're non-legal in the US at this point. They've been adopted, since the 1970s in Europe, Canada, Australia. Philadelphia, a federal judge ruled that it was not illegal, but there's been some opposition about its placement. So I think most people are familiar with naloxone at this point. So I just wanted to briefly mention that naloxone is cost-effective as an opioid antagonist with minimal adverse effects that can reverse overdoses. And we know that it is effective when it's distributed in the hands of people who inject drugs. This graph is actually from a study done by my mentor in Boston, Dr. Wally, who looked at overdose mortality and from 2002 to 2009. And in communities that had high enrollment, which is depicted by the green line there, of naloxone distribution programs, they found a 46% decrease in overdose deaths. So we know naloxone works. We know it especially works when it's given to people who need it. And for the final part of the talk, I just wanted to spend some time talking about our rural heart study. Rural HART stands for Rural Harm Reduction, Access, and Regional Trends. And the idea for this study really came from this infectious disease and substance use disorder syndemic that we're seeing nationally, but also in Maine, as I mentioned. And I'm part of the Infectious Disease Society of America and HIVMA, our professional societies. There's a work group for opioid use. And we just actually had a paper published this week. I put the reference in the slides for federal and state policy recommendations to prevent and treat infections related to injection drug use. And one of the policy recommendations is the expansion of syringe service programs. And so for this study, we really wanted to learn more about we're seeing these infections. Are people using SSPs? If they're not using SSPs, why not? And so we wanted to dig a little bit deeper. And, as Gordon and Jamie mentioned, the landscape in Maine has changed a little bit over the past few years, which I think is great. But at the time of the study, this was sort of the landscape of SSPs in Maine. So the orange counties here are the counties that were deemed high risk for HIV and hepatitis outbreaks by the CDC. And the green stars indicated syringe service programs at the time. And when the study was happening, again, Maine had the 9th highest rate of acute hepatitis B and C. About 10% of HIV cases were thought to be attributable to injection drug use. And again, we had one of the highest rates of drug overdose deaths in the United States. And unfortunately, I think we are still in the top 10 for that. So our aims for this study, our first aim was really to characterize knowledge, attitudes, and practices around safe injection techniques. And the second aim was to identify factors predicting SSP utilization and other services. And again, our goal was to really help potentially provide new information about SSP use in Maine and identify potential barriers. And our main hypothesis was that distance from SSP would be an important predictor of SSP use. So for our study, we recruited participants who were hospitalized with injection drug use associated infections at 4 different hospitals in Maine, you can see there. And over an 18-month time period, we enrolled a convenient sample of 101 patients. Unfortunately, our recruitment was cut short because of COVID-19. And we collected data through a patient survey that was done on a laptop. They had headphones, did it while they were hospitalized. And we also collected data through electronic health record. And as I mentioned, our main outcome was really SSP utilization. We did look at a bunch of other outcomes as well, as you can see listed there. But for the purposes of this talk, I'll be focusing on SSP use. So in terms of the main outcomes in past 3-month SSP utilization, you can see in the red bar graph there, 65% of our study participants reported past 3-month SSP use. So interestingly, only 10% reported always using a clean needle or syringe every time that they injected. And we collected a ton of variables, but this is just a snapshot of some of the variables that we were looking at. The first column is select demographics. The second column is the overall study population, again, which was 101 patients. The third column is the 65 participants who reported past 3-month SSP use. And the fourth column is the 36 participants who reported no past 3-month SSP use. And generally speaking, this is a young population. The median age was around 35, mostly white, 55% female. And a majority lived more than 10 miles from an SSP, 57%. And I did also just want to point out that about 89% of the population had a history of incarceration, and almost 50% were experiencing homelessness. And among the 36 participants who denied any SSP use in the past 3 months, notably 81% of them lived more than 10 miles from an SSP. As I mentioned, we did look at other outcomes such as the uptake of medications for opioid use disorder, naloxone, clean drug equipment, and generally speaking, as you can see highlighted in red, the participants who used SSPs had higher uptake of all of these services compared to those who did not use SSPs. And again, we asked the participants a lot of questions about injection drug use, how they were injecting, what they were injecting. And generally speaking, when asked about their drugs of choice, not surprisingly, most participants reported opioids as their drugs of choice, although 30% reported stimulant use as their drugs of choice. And I think this really reflects what we're seeing on the national level as well. One thing I wanted to highlight that you can see in red there is that 66% of our participants were on medications for opioid use disorder prior to admission. So again, these are patients that are admitted with infection. So I think this speaks to the stimulant use that's been going on, and also the lack of treatment we have for stimulant use and the importance of harm reduction services. This is a very busy slide, but I just wanted to really provide a snapshot of the different types of injection practices we asked about. So the orange picture kind of depicts something that they were doing rarely or never. Yellow is sometimes, green is half the time. And generally speaking, participants were not using new needles or filters or cookers, sterile water when they were injecting regularly. And as an infectious disease doctor, I thought these were also two very interesting practices in that a majority of participants were licking their needle, many were re-injecting their needles. And again, these are behaviors as an ID doc that I think are helpful to talk to patients about if they're actively injecting, because we're seeing a lot of infections from skin bacteria or bacteria that are found in the mouth. We also looked at something called the Bacterial Infections Risk Scale, or the BRCI scale, and I won't go through all of the variables, but two of the practices I wanted to bring up were hand washing and use of alcohol pads, which were two practices that participants rarely or never did. And in terms of syringe acquisition, as I mentioned, 65% of our study population did use an SSP in the past 3 months, but only 36% actually used an SSP regularly. More than half reported trouble accessing one. More than 57% of participants, as I mentioned, lived more than 10 miles from a program. And you can see from the map, so the dark brown areas are the metropolitan areas, and the tan, yellowish color, I guess, I don't know, is more rural areas. And the SSPs are the dark red circles, and there's sort of this 10-mile buffer zone that's drawn around the SSPs. So even if just looking at the map, at the time of the study, these were the SSPs that were available, and you can see that people living in more rural areas and some metropolitan areas would have a long way to go to access an SSP. And we did ask participants about syringe disposal. Most participants, 70%, reported at some point keeping needles to reuse on themselves. As you can see from the picture on the right, reusing a needle even after one time is not great. It becomes blunted, it causes, and it really can be caustic to the veins and also put people at risk for infections, as I mentioned. About 30% of participants reported disposing needles in the trash, and about a third reported returning needles to an SSP. We did ask about overdose risk and prevention in our study. About half of participants reported naloxone uptake, which we defined as either having naloxone used on them or used on someone else. And most participants reported receiving naloxone from an SSP. And if you look at the pie graph on the left, we found that 90% of our study population reported injecting alone in the 30 days prior to their hospitalization. And I think this speaks really to the stigma associated with substance use disorders and also the high risk of overdose for our patient population. And the second pie graph shows that a majority of our study population, 86%, supported supervised injection facilities, which I mentioned are medically safe places where people can go to inject drugs, not yet adopted in the United States, however. And the third graph shows that a majority of our study population was interested in mobile harm reduction units in our state. And again, one of the outcomes we looked at was uptake of medications for opioid use disorder. The pie graph on the left shows, as I mentioned before, that 66% of our study population was on medications for opioid use disorder prior to their hospitalization. And the pie graph on the right shows that a majority of our population, 67%, were prescribed buprenorphine. So our main outcome of the study, again, our main goal was to figure out, what was predicting SSP use. And we found that people who inject drugs were 5.5 times more likely to use an SSP if they lived within 10 miles of one. And this is controlling for a bunch of other variables that we looked at, such as homelessness, history of overdose, having a primary care physician, gender, and age. So again, distance really proved to be the main issue. So our study conclusions were that unsafe injection practices were common. There was specific behaviors and techniques where more counseling could be helpful, and it was evident that people were having trouble accessing clean equipment. And we found that there was lack of consistent SSP utilization, and that distance was really a significant barrier to use. So in the remaining time, I just wanted to talk a little bit about our ongoing COVID-19 study. And, you know, unfortunately, COVID-19 has caused a lot of bad outcomes, but one of which is an increase in overdoses among people who inject drugs. And these are national data. The bar graphs in red depict the time period that was pre-stay-at-home orders in January and February, and the yellow graphs indicate overdoses and post-stay-at-home orders, so from March to May. And unfortunately, nationally, we've seen an 18% increase in overdoses. And, you know, in talking to people in the community here in Maine, there's a lot of overdoses that are not being reported, so I suspect these numbers are even higher, you know, in reality. And as you heard from Gordon, you know, unfortunately here in Maine, the number of overdoses we saw in the first quarter were very high, and I think we're on a trajectory to surpass last year's numbers, which is quite unfortunate. So the aims of the study that we wanted to look at, we had a few aims. The first aim was really to understand the effects of social distancing on overall health for people who inject drugs, with really a focus on facilitators and barriers to accessing harm reduction during the pandemic, and also lessons learned from service delivery. Our second aim was to identify differences in acute care utilization in patients at Maine Med before and after social distancing measures were put in place. For the purposes of this talk, I'll just focus on aim one. I will actually be presenting complete set of the results at Maine APHA if anyone is attending that. So for aim one, we did 28 semi-structured interviews with stakeholders, which included people who inject drugs, some who were actively using, some who were in treatment or in recovery, community partners and providers, and we interviewed key informants until thematic saturation was reached. And here I have listed the main facilitators and barriers to accessing harm reduction services during COVID-19 that we found so far. And one of the main facilitators that we found was really these relaxed policies. So again, as you can see from the first quote here in the state of Maine, we've operated this one-for-one needle exchange. And that's something, again, that has been lifted with the executive order temporarily, and that we're fighting to maintain in COVID, after COVID, I should say, because we feel really, really strongly that we can't go back to how it was before COVID. That would just be really, really devastating for us. And again, mobile outreach has been very helpful. Many stakeholders have said that having more mobile units in rural areas has been key for facilitating access to harm reduction. And also the mail delivery of drug equipment has been especially helpful for people who may not have transportation or who might be having some issues with feeling stigmatized, et cetera. So these are really the main facilitators that we found so far. And in terms of barriers, one barrier that we found was decreased capacity. Particularly, I think this was in the setting of March and April when we were really all just trying to figure out what was going on with COVID. And there were, restricted hours, staff shortages, mostly because if a staffer got sick and other people had to quarantine, that was obviously challenging. And also supply shortages, not so much of drugs, but of clean drug equipment. So, trying to find things like hand sanitizer or alcohol pads for clients can be even more challenging during COVID. We also found that just, physical barriers, having to maintain 6 feet apart is also really challenging when you're trying to deliver outreach and services. If people have to wait a little bit and stand 6 feet apart, they might be, less likely to wait around. And I mean, I will say people have gotten pretty creative, and in one interview, they were holding out drug equipment on a pole so they didn't have to get within 6 feet of people. So people are definitely trying to reduce barriers if they can. And also there's some issues with decreased privacy. Some folks might be more comfortable going into an SSP rather than, going to because of the stigma potentially. The second quote I thought was interesting to include. Someone said, I have seen a lot of abscesses and cellulitis directly linking to injection drug use, and there have been a lot of patients reusing supplies for weeks on end. And I think, again, just speaking to some of the supply shortages and barriers that we're seeing during the pandemic. And we did find several other themes. I don't have time to talk about all of them, but I wanted to highlight a few. And one was really exacerbating current problems like stigma, domestic violence, food insecurity, and homelessness. One quote says, you know, I use a lot more, it's a lot harder because of stress. And, you know, using in the bathroom when you haven't bought any food there, they look at you like you're the devil. So again, I think this quote just speaks to the stigma of people who may be actively using that they're experiencing. And the second and third quotes, the second quotes, you know, it's almost like a luxury in a way to be able to think about COVID and stay safe. I have a lot more things to be afraid of than COVID-19 on a day-to-day basis. And I think this really speaks to the basic needs that people are struggling with during the pandemic. You know, like food insecurity, like homelessness. You know, we had in several interviews, you know, people just saying, I'm more concerned about where I'm going to sleep tonight or where I'm going to find food, you know, than I am about COVID at this point. And I'll sort of just paraphrase this quote, but I think it really speaks to or summarizes well what we've been talking about. So I think it brings me back to the point of how in America we need to have harm reduction and really start to look at things like safe consumption sites. In other cities and states, at times police officers have access to clean syringes for consumers. I think if we had been a little bit more progressive in our harm reduction approach and been a little bit more like other countries and really focused on reducing the spread of illnesses and reducing overdose. So you think of what we've learned through COVID, and you've seen a lot of these things, whether it's kids that can't eat unless they're at school, or all these social issues we've ignored for a long time now. They've got a microscope on them. And it will be a disservice to all of us once this is over with if we don't look hard at these issues and go back to the drawing board. And I do, on a positive note, I will say that one thing that's really come through in a lot of the interviews that we've done is really the resilience and commitment of the community. As you can see from this quote, you know, I think it's really been pretty amazing to just see how resilient people are and to really find these creative ways to connect. And this is something we've heard over and over again, and that's, you know, community organizations really working together to try to get people the services, and really providers and community organizers bending over backwards to really try to mitigate some of these barriers that people are finding. So some of the conclusions from our COVID-19 study is that we identified several barriers and facilitators to accessing harm reduction services. We've also found that there's been this exacerbation of underlying issues that really still need to be addressed pre and post-COVID, such as stigma, domestic violence was another one, homelessness, but also that there's just been resilience of the community. So finally, in the last minute or so, I just wanted to talk a little bit about just, you know, discussion and take-home points. As I mentioned, harm reduction is really a social justice movement, and I hope that I've conveyed that it encompasses non-judgmental, very practical strategies that mitigate negative consequences from drug use. And I think our research has shown, and other policies have shown, that expansion of SSPs is really needed, including mobile units, and I think it's fantastic that our state has done so, especially during COVID, and will continue to do so. And again, just given the overdose risk and infection risk in our patient population, I think we do need to consider something like a supervised injection facility. And also, again, from our research, I think the relaxed policies have really helped how people are accessing harm reduction services. And, you know, from a public health perspective, I think these would be important to maintain after COVID. Again, that includes the elimination of the one-for-one needle exchange, allowing secondary peer exchange and mail delivery of equipment. And again, just generally speaking, approaching drug use as a public health issue. And, you know, as I mentioned, people can be punished if they have a certain amount of needles on them. And I think just really decriminalizing drug use. Again, as an ID doc, I would much rather have someone have access to clean needles than get in trouble for having, you know, a certain amount of clean needles on them. So I listed some resources here. Actually, it was a link that Jamie provided with the operational SSPs in Maine, which include the new ones, I believe. And the second resource is the policy paper that we just published this week from IDSA and HIVMA on federal and state actions needed to prevent these infections from injection drug use. I also provided the American Society for Addiction Medicine COVID-19 guidelines that I was involved with. We just updated them in June. And they have a great section on harm reduction. I did not write that section, but, and then also the fourth resource, the Harm Reduction Coalition, which as a clinician, I find really helpful. They provide very practical guidance for harm reduction approaches during COVID-19. And the fifth is the book chapter I mentioned that we just published on harm reduction services, if anyone wants to learn more, because I really just sped through some harm reduction principles. So for acknowledgements, I really just wanted to thank the study participants who gave their time and insight to us. Also the funders and the study team. As you can see, it really took a lot of people to make these studies happen. So I really want to thank all of my collaborators. These are my references. They're my email. You can find me on Twitter. And then I think, as Gordon mentioned, the Maine Harm Reduction Conference information here, Friday, October 30th.
Well, Dr. Thakarar, thank you. And we do have a couple questions that I couldn't answer that I said I would ask you live. The first was the reference to the licking of needles. And the participant asked, why is the licking of needles a common practice?
Yeah, my understanding is, and there's probably more experts on this than me, but my understanding is that oftentimes people are licking them more just to get residual drug and to inject that. And sometimes something that Zoe and people from SSPs have taught me is it's also often just part of the ritual of the injection process. So, but the main thing I think is trying to get residual drug to inject.
Okay, and our friend Becky Shagwasulis asked, she was surprised to see that 60% of the of your participants were on buprenorphine or Suboxone. And she asked whether you thought that was similar in national data. Is that unusual, or what would you expect?
Yeah, I think that finding was pretty novel. I mean, I'm not sure that people have looked at it specifically in this setting, but we were surprised by that. And I think, although on one hand we were surprised, but also we know that we're seeing more and more stimulant use. It's, this fourth wave of substance use. And, a lot of the infections that we're seeing are because people are injecting stimulants. We just don't have great treatment like we do buprenorphine and methadone. So surprised on one hand, but not surprised on the other, I guess. But
there was a question about what, as a citizen, a person can do to help. We all three probably can take a shot at that. So, why don't you go first, then Jamie, and then I'll clean up.
Sure. I think really just, advocating for people. There's a lot of bills out there, specifically, decriminalizing drug use and, just letting your representatives know, getting involved if you want to volunteer at some of the SSPs or help distribute naloxone, do naloxone education. But yeah, I think also just the main thing is advocating and getting involved with some policies.
Jamie?
Yeah, I would agree with what Dr. Thakarar said. And then to add on to that, I would say I think that everyone here today has taken a great step of learning more about harm reduction and syringe service programs and the challenges that folks with opioid use disorder or persons who inject drugs face on a day-to-day basis. And so I would encourage folks to also have discussions beyond today within your social circles to help other folks become aware and understand some of the challenges that folks face, and also the reasons why we support harm reduction as a philosophy. Because I think that addressing the stigma is a really important step for us to take as a society to help folks feel comfortable accessing the services that they need and empowered to do so. And so that's my 2 cents to add on to what Dr. Thakarar said.
I frequently am asked this question on the broader question of our strategic action plan for opioid response, which focuses on four areas: prevention, treatment, recovery support, and harm reduction. And there is something that every Mainer can do to help. In prevention, you can mentor a young person. We have so many young people that are getting into difficulty with alcohol by the time they're in middle school. And we need adult, you've all heard that every child needs, at least, a responsible adult. I would say 4 or 5, whether they're parents, grandparents, aunts, uncles, but it can be a next door neighbor or teacher as well. I would also encourage you to see if there's a recovery center in your area. We have 13 recovery centers now, from Calais to Caribou down to we're about to have one in Saco, and lots of places in between: Bridgeton, Bath, Booth Bay, the Barn up in Brewer, and certainly our Portland Recovery Community Center, the PRCC, which is the hub for all the other centers. So they do need volunteers, and they have courses all the time to become a recovery coach. And if you can't do the 4 days to train to be a recovery coach, they now have a 1-day kind of overview of what it entails. You won't be a certified recovery coach when you get done that 1 day, but it might be enough to tell you whether or not you'd like to commit to the 4 days. So there is, everybody needs to be engaged in this, and anything that you do personally to reduce the stigma. You've heard the governor and I talk about the fact that we're not clinicians, right? We happen to be lawyers. But we understand that it's a chronic, that substance use disorder is a chronic illness. And every day we talk to people about the fact that persons with substance use disorder should be treated no differently than people with diabetes and chronic heart disease. And there's been discrimination, and it's forever. And the time has come to, now many years after the Americans with Disabilities Act, we need to treat these illnesses the same as any other illness and treat people with compassion. So I'm really glad to get that question so that we can put that information out there. I'm trying to see whether there's other questions that we said we would do live. Yes. What does the term reuptake mean regarding addiction language? I think I know, but Kinna, why don't you take that?
Yeah, we just wanted to, I think I had used that as medication for opioid use disorder uptake. So we had just sort of defined that as any use of medication in the 3 months prior to our particular study participant hospitalization. So that's how we had personally defined uptake. So.
Okay. Is there a plan for harm reduction in SSPs for Aroostook County? Yes, there's an SSP about to open in Caribou with the support of the terrific police chief there, Mike Hagan. It's been certified, I believe, and I believe that the contractor is Maine Access Points, and it's probably due to be open any day. I know that the location, I believe, is going to be over near the recovery center. So absolutely, that will be the first SSP in Aroostook County. And it is more than just on the drawing board. It is about to open if it hasn't already. Another question, okay. When you say decriminalize substance use, are you referring to only in the setting of SSPs or across the board? I'm not sure who used the term. Was it me, Kinna, or Jamie? Kinna, probably?
Probably.
And you probably refer it across the board, really. I mean, I certainly believe that that we have incarcerated people who are primarily and prosecuted people who are primarily ill, and that the focus should be on getting treatment. And if they are incarcerated, I absolutely endorse the concept of our drug courts, and the drug courts are doing a terrific job, I think. But you wish that the people had never reached that point in the criminal process anyway. Again, many of them have committed crimes, and you can't always absolutely ignore that. But I think we all recognize that treatment, and treatment even before as an issue of harm reduction, that, you know, we have housing first now. It used to be, oh no, you can't get in a recovery house unless you're completely abstinent. Well, sometimes this is unrealistic, and we know that people who are compromised in their home situation or homeless are not, they're not likely to be successful in their recovery from substance use disorder. So they need, their basic needs need to be attended to. And that's been clear in my calls with my national colleagues and my colleagues in New England. So we also have medication first. You know, there are still programs that, you know, if you test positive for marijuana, they won't continue to treat for your substance disorder. Please, come on. It's 2020. So lots of work to do, but you know, while I'm not prepared to say that we have to, that we're going to decriminalize all substance use, we certainly need to decriminalize the possession and trafficking of needles. And no doubt there's a number of other criminal justice reforms that I know our colleague from the legislature, at least two of them are on the call, and they're very active in this area of criminal justice reform because of the impact it's had on substance use disorder. So we are working on it. All right, it is 12:30. I want to thank particularly Kinna and Jamie, and also for their time and expertise and advocacy, and also all of you. I hope we'll see you again in October. Watch for our emails, and again, have a great Labor Day weekend. We all deserve it.
Thank you, everyone.